Hello, welcome to Addressing the Heroin Epidemic. I'm Joe Wren. Drug addiction is having a devastating impact on communities in every state across the country. And one of the few political issues that saw bipartisan agreement this year was the Comprehensive Addiction and Recovery Act. You've maybe heard it referred to as CARA. It's the first new piece of drug legislation in about 40 years. Tonight we're going to delve into what CARA does and doesn't do, and whether it addresses the urgency of the opioid epidemic. Let me introduce our panel. Justin Phillips is the founder of Overdose Lifeline. Tom Synan is the director of the Hamilton County Heroin Coalition Task Force. Emily Walden is the founder of the Stop Now Kentucky chapter and a committee member of Fed Up. And Dr. Andraka-Christou is a postdoctoral fellow at the Fairbanks School of Public Health at Indiana University, Purdue University, Indianapolis. Welcome to all of you.
Thank you.
So, Tom, let's just start with you. I think you've heard this before. It's the 30,000-foot view. Can you give us a little bit of an overview of how widespread this problem really is?
Well, I'll just talk about some numbers. We thought we had an epidemic when we had 20 to 25 overdoses a week with 1 to 2 deaths. The spike hit us in Cincinnati. There was 175 to 200 overdoses in 1 week with 3 deaths. This past weekend we had 97 overdoses just alone in 2 days. We are averaging 5 deaths a week. To say it's an epidemic we thought it was an epidemic at 20 to 25. Every day we were responding to 20 to 35 overdoses a day. So you talk about urgency, I think we're beyond urgent.
Yeah, well, and a CDC numbers show that more people die from overdoses and heroin than gun violence and even car accidents. So how did this happen so quickly, and how do people not know about this?
Well, I think the piece did a great job of describing it, the opiate addiction from pain pills and Oxycontin, oxycodone. 10 years ago, we were fighting the opiate addiction of selling pills. People coming in with a bag full of pills and selling those. But we didn't have many overdoses because when you bought a 50 milligram pill of oxycodone, you knew it was 50 milligrams, and plus was made by a pharmacy. The problem with heroin is, and I gotta tell you, we're beyond heroin now. We're into fentanyl and carfentanil and the China white. When I heard that is fentanyl. We started in 2013, we had 8 overdose deaths contributed to fentanyl. In 2015, we had 238. So it shows this shift of the dealers putting more powerful drugs on the street. You already have this opiate addicted society. And when you put drugs like fentanyl and carfentanil, which is meant for an elephant, there is nothing to expect but overdoses and death.
Jordan, are we ignoring this issue overall?
I don't know if I would say that we're ignoring it. Yes, we are ignoring it. But we're also really ignorant still to the fact that prescriptions and heroin are the same, and that the prescriptions, lead to the heroin. There's so many people that we talk to every day that still don't realize that. So yeah, we're ignoring it as far as an epidemic or a crisis is concerned. Absolutely. I don't think we put the resources behind it the way we do other public health crises.
I have a little information here on CARA. I wanted to just some background. It expands access to naloxone and medically assisted treatment. It authorizes grants to treatment programs and to states that have high rates of opioid use, and it creates a task force to look at how opioid drugs are prescribed. Now, we're going to talk about funding later, so if we can hold on to that for just a second. But just a question for all of you, is CARA focusing on the right issues?
I think it's definitely focusing on the right issues. In fact, having read the legislation very carefully, I was quite impressed with the amount of effort that's going into expanding evidence-based treatment options. And one of the things that I've been concerned about for the last couple of years is focus on prevention, as if, we only care about people before they become addicted, but not much focus on evidence-based treatment. kind of like, once you hit that threshold, we're not there to help you anymore. And I think that was the case for a long time in the criminal justice system. We just kind of closed the door on you. And I think finally we're waking up to the fact that treatment is a big deal, and most importantly, treatment works. And I think there's this misconception in America that addiction is an acute condition that doesn't really need treatment, where it's actually a chronic condition that has treatment success rates equivalent to asthma or hypertension. So I think this act actually did a really good job zoning in on expansion of treatment methods, and I think that's really what was needed at this time.
Emily, do you agree with that?
On the treatment part of the bill, yes. On other parts of the bill, no. There were mandatory prescribing program that was in the bill originally that would prevent people from doctor shopping across state lines. That was taken out. There were other things added in that benefited the pharmaceutical companies that created this epidemic to begin with. But I do believe, I agree, the treatment part of it, if it is funded properly, yes, it is. It would be a very good thing.
Tom, I feel like you wanted to jump in there.
I was going to say, this is law enforcement's cry, is to make this a public health issue. We always talk about not arresting our way out of it, and we've been some of the strongest supporters of medically assisted treatment. I know in the Cincinnati-Hamilton County area, that has been our big push with the coalition, is let's push this to the hospitals and the doctors and the people that can treat it. We were at a meeting with the Attorney General yesterday, and one of the leading doctors and addiction specialists said if someone had a heart attack, they would go to the hospital, see a doctor, be treated for that heart attack. But what we do with the user is they overdose and we walk away from them, and they're not even going to a hospital. So if it's going to be a public health issue, if we're going to call it a disease, then that's where it should go, is to the medical professionals, and let them treat it.
According to the DEA, 4 in 5 new heroin users start out by misusing prescription painkillers, and we heard from Indiana Senator Joe Donnelly, and let's see what he had to say.
You have some prescriptions that, for instance, you have your wisdom teeth pulled, and prescriptions have been given for 50, 60 Vicodin or similar type opioids, and you don't need those after like 2 or 3 days. And so what you have is in the medicine cabinet, in effect, like 50 or 60 of these opioids just sitting there. And they are like time bombs sitting there. And so what we're trying to do is to match up the actual needs of the patient with the prescription that goes out.
So, Emily, I'll ask you this question. What does CARA do to regulate pharmaceutical companies that market these drugs to doctors?
It doesn't do anything for that. What they did was they're giving rebates to these pharmaceutical companies in order for them to create abuse-deterrent formulas. The misconception and the wording that has been used over and over again, you can still become addicted by using these drugs as prescribed. The new CDC guidelines that were released this year are most important for doctors and patients. You should be asking your doctor, do you follow the CDC guidelines?
Baja, would you like to follow up on that?
Well, so in CARA, it's very interesting. Actually, in the VA system, CARA does a lot to sort of address this issue of guidelines and imposing them on physicians. In fact, there's wording in the legislation saying that physicians cannot actually prescribe opioids in the VA system unless they've gone through special training, unless they've done random drug screenings, unless they've checked a prescription drug monitoring program to make sure the person isn't doctor shopping. Unfortunately, none of that is required of physicians outside of the VA system. And there's a strong argument that people make that this should be a purely state-based decision. And, perhaps that is true, but I think we've gotten to the point now where, because it's an epidemic, we need to at least be having the conversation as to whether this is something the federal government should step in and the federal government should mandate. One thing the legislation does do, for example, is require the FDA to convene a committee to come up with recommendations for education for physicians, but it doesn't actually require the physicians to get the education. It's just, recommendation that maybe other medical boards could look to and take into account.
It also has a pain management task force in there made up of these associations, nonprofits that are funded by the pharmaceutical companies that could interfere with the CDC guidelines that were just released.
So how do you change how doctors prescribe medication to patients that are suffering legitimate pain, but then of course you want the patient to have satisfaction in the treatment? How does that
We
happen?
need FDA policy changes. They should not be able to market these drugs inappropriately. And I think that's been a big problem with this epidemic to begin with, is the marketing of these drugs.
Well, I think that the main issue when you look at physicians is not physician bad behavior. I think most physicians are absolutely wanting to help people. They're not out there just to make money. The problem is that physician education is really, really low currently in medical schools, and especially historically when it comes to treating chronic pain and also when it comes to substance use disorders. So if you look at the average physician, they've had a couple of hours of lectures period on substance use disorders. That's what one study showed, for example. Fortunately, CARA does attempt to address that. It actually provides grant options for expansion of physician education programs and also educating medical students and residents, and that's something that I think is really badly needed.
Jordan, you wanted to pop in really quick?
Sure,
Yeah.
it's Justin.
I'm sorry,
Joe.
Justin, I'm
No,
sorry.
it's okay. I'm sensitive, but
You should be.
well, because most people think I'm a man. But anyway, I think it's also important to empower the people to understand that you take it as prescribed, but that doesn't mean you continue to take it beyond the pain. Try a Tylenol, try an Advil, something other than the prescribed medication. I don't think the average public understands that. They trust the doctor. So I agree that it's not necessarily the doctors having the bad motive, but it's just the understanding around the danger to the drug and the short term that we should actually be using them.
We have a question from the audience. Eric Bates, go ahead.
Yes. Something that I find troubling is that if this is a medical disorder, why can pretty much any doctor prescribe strong opioids and narcotics, but not every doctor can prescribe medically assisted treatment that was talked about?
This is an issue that I have written extensively about and I'm very passionate about. I think it's extremely problematic that buprenorphine is regulated more stringently than oxycodone. Methadone is the most stringently regulated medication in the United States that is FDA approved. And yet, for example, in Indiana, for a while it was the case that methadone was not covered by Medicaid for addiction treatment, and yet Medicaid would cover it for pain management. And so we've had just this very bizarre dichotomy of regulations that almost favor pain medication or medication used for pain management. But if it's something for addiction treatment, then it was very almost like a hands-off. We're scared. We're going to put as many barriers as possible, and let's hope somehow people will get access to it. Well, they didn't. And I think that the federal government is starting to take some good steps. They lifted the patient limits, the Department of Health and Human Services recently, on certain buprenorphine prescribers, and I think that's a good step. No other medication in the U.S. has patient limits. And again, if you look at the legislation for that created these patient limits, it's often based in misunderstanding. There were discussions that were held at the DEA level and the DHS level talking about how, well, this is just so addictive to the average person who's not opioid dependent that we need to focus on them. Yes, the average person who is opioid dependent can feel some kind of high potentially from something like buprenorphine, but the dependent individual is not going to get a high from buprenorphine. This is actually going to help the dependent individual. So part of it, I think, is also stigma of favoring people who are not already dependent at the exclusion of people who are dependent.
I wanted to bring up naloxone. I've even talked to an Indiana mayor who said that the fire department sent someone to the same place twice in one day. So the question becomes, and maybe Tom, you can take this, what happens after naloxone?
Well,
how do we get to that recovery point?
Well, we don't have anything. So from a police side, it's very difficult for me because I have this thing called the Constitution. So the Constitution limits me from taking people from one spot and putting them somewhere unless they commit a criminal offense. One of the things I've been trying to push for is allow the police to be a link. We do it for the mentally ill. But there is no way we would allow someone that's intoxicated on alcohol we would never walk away from them. They would be a harm to themselves or someone else. So I'm trying to get this link that would allow legislation to allow the officer to take them to a treatment facility. And I get the pushback from the user, and I understand it. If someone's not ready to get treatment, it may not work. But my thing, it's better than walking away. It is at least them sitting in front of somebody, getting to know somebody, and maybe they do get talked into treatment. And if not, and they leave, at least they got that contact. This is the problem. We are reviving people and walking away. In the city of Cincinnati, they revived the same person 4 times in one shift. So we're in this never-ending cycle, and what we talked about yesterday was the fatigue of the first responder. And it's not just the police officer, it's the firefighters, the dispatchers, the nurse, it's the doctor. They're getting wore out. And my call to legislation is let's get some laws that allow us to, number one, help the user, and number two, help society.
Now, did you want to?
There's some parts of the country that are doing it maybe a little better than we are here in the Midwest, where they do have those programs set up where, as Tom mentioned, law enforcement is able to facilitate those individuals getting into treatment. I know in Indianapolis there's a pilot project taking place where the social worker is meeting that individual in the hospital, because we do want them transported to the hospital following administration of naloxone. So I know that there are options, but it's a funding and a resource problem.
But how about for those, Justin, that say, well, naloxone is just a safety net for people to use heroin?
Right. Well, I think that you have to understand what it's like to be a user. And I myself am not, recovering from opioid dependence, but I've learned a lot since the death of my son, and that's just not part of their thought process. Nor is it the thought of someone who suffers from diabetes when they consider adjusting their insulin to be able to eat sugar. You know what I mean? So it's just not that way. They're just trying to survive.
And that's one of the issues I'm passionate about. It bothers me that this is the one segment of society that they tell me, and I've heard it, let them die. Mm-hmm. Why go to an auto accident where it's the 4th or 5th time someone was drinking and driving? Society doesn't tell me to let them die. I was on a person who tried to commit suicide 12 times. Not once did society tell me to let them die. Actually, what they told me was, risk my life to save theirs. I don't understand why this segment of society is different than anyone else. So to me, it's not an enabler, it's about saving lives and giving them an opportunity.
I wanted to get into some of the funding behind CARA now before we run out of time. It authorizes $900 million in funding, but it has to go through the appropriations process. So what is the reason that maybe a politician or senator would oppose this funding? Justin?
I cannot answer why they would oppose it, other than they don't understand the need. They're not willing to address that we have this epidemic. The challenge is that they have not addressed the appropriation.
Well, historically, there was the idea that you had to be tough on crime, and that really goes back to, the Just Say No era in the 80s. And it was viewed very negatively for a politician to devote money for treatment as opposed to money for criminal justice. And I think that now that we're starting to see, for example, on the stage, criminal justice coming out and saying, hey, we don't want to be dealing with this issue. This isn't our issue. I'm really hoping that politicians will start to get a different message, which is not, I need to be tough on crime, but this isn't even a crime, really. This is a public health issue.
Emily, you want to chime in on this too?
Basically, it's approved for funding, but through the appropriations process, they have to take money from other places and fill those buckets, basically. If we had mandatory or emergency funding, that funding would be renewed every year. It wouldn't have to go through all that, and we would be guaranteed the money. So I am disappointed that Congress has not taken that route. At this point, as of today or yesterday, Congress did approve $37 million to get us through to January, I believe, but that's minimal. I mean, if you divide that up, that is hardly any money.
So let's say the money is appropriated. How much of that would be considered new money compared to what's already there? Does anybody know that?
I do not know.
I do not know.
Basha, no.
I don't know, but I know that there's certain provisions in the grant, or sorry, in the legislation that specifically say this money is to be used for grants that supplement existing funding, that it can't replace existing funding. And so, you know, there is a little bit of a concern in my mind, you know, what happens if there's a community that just doesn't have any funding? Are they going to get it? You know, is that considered substitution? Well, there's not any money there yet, but maybe it's not considered supplanting. So there's actually a little bit of legislative interpretation that, you know, may be at issue eventually.
You know, there was some uncertainty to whether the president would sign CARA because it didn't provide funding, but he proposed a plan that would spend, I have here, $1.1 billion, though largely on treatment programs. So now can both of these programs get funding, or what happens?
They're not going to approve it.
No.
They've already said they're not.
Yeah.
Congress has already said they are not going to approve the president's budget.
So then Obama's plan is essentially dead.
Yeah, I was there last week, and I was told it was a no-go.
I think that there's, you know, hope for that, but unfortunately we're in a fairly large election cycle, and that interferes.
You know, from the person on the street, I'm seeing this. I'm seeing the overdoses and the deaths, and we need money, we need funding, we need manpower, and for people to sit, like you said from the beginning, 30,000 feet and make a decision. Yeah, I'm making a decision right then to save someone's life. And when we walk away from Narcan, to know that all it needed was someone to have enough money to take them to treatment, then I don't understand why we're not getting that on the street. And we talk about certain laws. You know, the laws aren't the answer. What they need to do is start from the street and work up. We need to have the input in the law because we're the ones seeing it. Casey's Law, for example, I've got a father whose daughter is in Cincinnati. She's probated under Casey's Law in Kentucky. She's literally 5 minutes away, and we can't take her across. I got a father begging me to basically kidnap her, which is illegal for me to do, and just drop off her. He goes, literally, just take her to the river. I'll have a cop meet you there. But I can't do it, and she's literally 5 minutes away. So here's a law that's supposed to be helping, but there's all these blocks. I think it's time that we really get serious, legislators get serious and sit down with us and say, what would make it easier for you to save someone? And let us start writing it, and then let them start enacting it.
Yeah, and I think it's interesting how you describe the buckets too, and that these buckets probably get smaller and smaller when it starts to get kind of trickle down into the different states and so forth.
And CARA is only enacted, I believe, for like 2 years, and then that bill.
And then it would have to be reapproved?
Well, it's a short-term bill, so that
Okay,
it's
right.
supposed to address the epidemic, you know, the immediate needs of that, while they're still looking at other legislation. In my opinion, we need to address the FDA, or we're going to continue to see new addictions occur. And then we need to help those who are currently addicted get into treatment as soon as possible.
We have some online questions I want to get to. So what does the next president inherit? So does the next president inherit this problem, essentially?
Yes.
Of course.
Definitely.
Yes.
It's not going away. When we set up the Heroin Coalition, we were looking at a minimum of 5 years. And that wasn't to end it. That was just to get stagnated, enough for us to catch our breath. This is going to be, we're in here for a while.
I mean, there's 23 million people approximately suffering from substance use disorder, and only 1 in 10 are receiving any kind of treatment. We have a long way to go before we're going to get ahead of this.
We have another online question I'll get to. Does CARA put more money into social services that are strained because of the opioid epidemic?
No, not to my knowledge.
Not to my
I mean,
knowledge.
I guess it depends on what you mean by social services, but I remember just seeing a very small provision that was, I think, $1 million per year for recovery communities that connect people to social services. But I seem to recall the main element was expanding treatment. So now you can consider treatment a social service, so I guess depends on what your definition is.
In the absence now of federal funding, can we talk a little bit about state and local funding? Is there any out there, and what's next on that?
I've been pretty vocal that the governor of Ohio needs to declare an emergency. I've gotten response back that he can't, and to be honest with you, I don't care what you call it. I don't care if you call it a heroin emergency, but there's $2 billion sitting up there, $100 million of that would go a long way in our area of Cincinnati and Hamilton County. There's money, at least in Ohio, on a state level, that we can make an impact enough, like again I said, to stagnate it, to catch our breath. It's just a matter of them up at the state level, the governor and legislators, declaring an emergency, so we're not going through this process of grants and that type of thing, and appropriations, and getting that money right to the streets where it needs to be.
The resources and capacity in Indiana is very bleak, right? We do have a surplus at the state, but I don't know that that's necessarily enough. We have so much rural area and nowhere near the amount of detox and treatment resources that we need. We really need that federal funding to meet the need.
We have another online question. Someone says that they've had a major back surgery and they're still in severe pain. What do? They were on oxycodone, where my 70-year-old mom was on Oxycontin. Now she lives in severe pain.
Well, I don't think any of us are doctors on this stage, so we can't legally give, medical advice. But just, knowing, for example, the CDC guidelines, it's very clear now from meta-analyses of many randomized trials that opioids for chronic pain are just not successful. For acute pain, they're very successful, but for chronic pain, we're just not seeing the benefits relative to the risks. So I would encourage that person to seek other alternatives. And I know, for example, there are starting to be more comprehensive pain management clinics where they take other things into consideration, such as physical therapy and even, psychological counseling, and those things have been shown to help somewhat.
So we're kind of starting to wrap up. Where do you hope that we are a year from now? Who wants to go first?
From the street level,
Yeah.
I would hope that we at least stagnated enough that we can drop the numbers from 20 to 35 overdoses a day. I would love to see CARA fentanyl off the street. I hate to say it, but that is what is really harming us on the street level at the moment. To be able to stagnate, to be able to catch our breath right now is what I'm looking for in the immediacy. And then the long term would be the treatment and medically assisted treatment and making sure that funding is there. But right now, from a first responder level, we just need to stagnate it.
Justin?
So for me, one of the things we do at Overdose Lifeline is we're really working hard to prevent that first use. So we really want to get the message to the young people before it's too late that this is not something you can experiment with. This is not a drug you can play with at your friend's house to decide.
Emily? Really quick.
My goal since the passing of my son 4 years ago has been to reduce overdose deaths. We need FDA policy change, and we need people to have access to treatment.
Well, I don't think this can happen in 1 year, but I would certainly want to see this being discussed as a public health issue rather than a moral issue. And I think that's really the answer to a lot of these questions we've had of why isn't this being funded enough. People just are not yet seeing it as a public health issue.
Thank you so much. I appreciate your time. Thank you to our panelists, and thank you for joining us this evening. You can find more of our coverage online at WTIUnews.org. Have a good night.